welcome to this week's episode. If you're just joining me, I'm Dr. Susan. I'm a board-certified gynecologist, 100% dedicated to taking care of women in midlife, women just like me in perimenopause, menopause, and beyond. And I'm often asked, what labs should I ask my doctor to do? Because let's face it, most doctors are not going to look that critically into your lab work because, frankly, they don't have time, and that's just a sad state of affairs. So we may have to take accountability for ourselves and ask for the labs that we need. So what I'm going to do today is actually go through a set of labs from a real live patient, actually someone I saw today, and I'll show you the numbers, anonymously of course, that we got, and I'll tell you exactly what I told her. So this will be kind of like a mini version of a consult that you might have in my office if you were to come to me as a patient. Now I will tell you that consult would normally take 60 to 90 minutes, so I'm going to shorten it a little bit because I know no one wants to watch a 90-minute YouTube video. But let's just go through these labs, and there'll be a list at the end so that you could literally ask your doctor to draw these labs, or you could go to a place like Any Lab Now and just order them yourself. So let's just start from the top. I'm going to read through these, and then I'll show you some screenshots as I go. So what we do with our new patients is we ask everybody to come in fasting, and that is with 8 hours of not having anything to eat or drink. Tea, coffee, or water is fine. The reason for that is that some labs are affected by food, like obviously sugar, cholesterol, etc. So the standard is to do labs in a fasting state. So that being said, this particular set of labs is from a post-menopausal woman. So just as a review, when we're post-menopausal, what would we expect? Remember, estradiol, the primary estrogen that we make in our ovaries, progesterone, and testosterone would be expected to be pretty close to zero. Now, if I were drawing labs from someone who was still having periods, that would mean perimenopausal, it would be critical for me to know what day of the month those labs were drawn. So if you're still having periods and you get this lab work done, the best time to do it is during your period. We usually say day 3 to 5, with day 1 being the first day of your period, or if your periods are regular enough to know when this might be, a week before your next period. So, for example, if your cycles are 28 days apart from the start to the start, a week before would be approximately day 21, or 3 weeks after your period started. Make sense? So, early in the cycle, or a week before your next period is the best time to do blood work. However, if you're not having a period, if you're menopausal like this patient, we would expect all of those hormones are zero. Make sense? So this particular video is specifically about lab work for a menopausal woman. That's someone who has not had a period for some months. This particular patient hasn't had a period for 3 years. Okay, so in no particular order, this is just the order that the lab prints it. First page, we're looking at, I'm going to go down to the bottom, a lipid panel. Now, basic lipid panel, and I've talked about this recently, is basic. That means it's not comprehensive. It's just a high-level look at what your lipid panel is with the goal of determining whether you're at higher risk of heart disease. So this particular patient, as you can see, has a cholesterol of 176 total cholesterol. I don't look at that number too much, but that is certainly in normal range. HDL of 64 is great. We want it to be something greater than 50. Now, if you look over to the right and look at these reference ranges, I'm going to tell you multiple times that I'm not going to be agreeing that that's an optimal number. But in this particular case, yes, HDL greater than 50, that sounds good to me. Forget the cholesterol-HDL ratio, that is not useful. Triglycerides less than 100, that's very good. So this patient has an excellent lipid profile so far. Low density lipoprotein, we want to be less than 100. So I can look at this and say this is pretty perfect. Another thing we want to look at is the triglyceride to HDL ratio. So in this patient, 74 to 64. That is an excellent ratio. We want it to be less than 2. So 2 is good. Less than 1.5 is rock star. So this is a patient who's not on any lipid-lowering medications. She's 58 years old. I'll just tell you, she lost 200 pounds. Did not look like this before, just as an example of how weight loss can completely fix your labs as well as lowering your cardiovascular disease risk, so go her. Now, let's pop up to the top. You'll see this number for ApoB that I talk about all the time. If you look back at the video I made about cholesterol a little while ago, talked a lot about these things. So ApoB, as a reminder, is a protein that's on the outside of these little packages of cholesterol. I think about them like little soap bubbles. And in order to float in water, they have to have protein around the outside. Otherwise, fat can't float in water, right? So ApoB is cool because it picks up not only low-density lipoprotein, or LDL, which we used to call bad cholesterol, but we don't have to call it that anymore. It's just doing its job. Not only LDL, but all the other alphabet soup. Low-density lipoprotein, that's LDL. Very low-density, intermediate density, lipo little a. What they all have in common is they have an ApoB protein on the outside. So ApoB of 79 is a pretty good number. We want it to be less than 80, so that is a very good number. Hey, even lower would be fine, as low as possible. If you look at that reference range, we do not want to be at the top. So remember, reference ranges are not optimal ranges. They're simply saying this is what people have. That particular one, you want to be at the lower end. So 80's fine, 60's better. Over 80, I would say, is too high. So great ApoB, great lipid panel. Now, because of that, we're not going to dig any further. But if those were not looking so pretty, we would dig further and do some more lab work to dig into it more. Again, this is just a very high-level, basic look, but this patient passed it with flying stars. Now, jumping down to homocysteine, that is a nasty inflammatory marker. We want it to be low, again, as low as possible. Less than 9, less than 10. The lab says less than 15, that's way too high. There actually are some very good studies showing that homocysteine, even over 11, is associated with a very large increased risk of Alzheimer's disease, for example. So homocysteine is a very long story that we'll talk about in another podcast, but it can be a marker of inflammation that can affect our blood vessels, and that's a very long story, very short. But if it's 8 or 9, that's fantastic. If it were 10 or higher, we would treat it. And we would treat it by taking B vitamins. So really simple. If your homocysteine's high, we give you a combination of B vitamins, including methylfolate, which is the active form of folic acid, B6 and B2. I like the product called MethylGuard. I take one of those every day. Basically, that is supplying a methyl group to complete this process called methylation. Too much to talk about today, except to say we want to have good methylation. That's what keeps our DNA healthy. Very, very long story, very short. Anyway, homocysteine's normal. If it's high, we want to fix that. Insulin. We've talked about insulin resistance a lot. So when we're fasting, we want our insulin to be low, because if we're not eating anything, our pancreas shouldn't be really producing much insulin because it shouldn't have much to do. So insulin less than 5 is rock star perfect. This patient's insulin is 4.6. That's really good. So if you look at this reference range, if you're at the top end, 20 or 24, you're already a really bad diabetic, most likely. This is another one you want to be at the lower end of. So reference ranges are, again, cannot say it enough, are not optimal ranges. Insulin, just like ApoB, you want to be at the low end of that range. So now, next page. I don't know why they put them in this order, but as expected, progesterone is pretty much 0. So why is it 0.13? Well, that's because we do have some peripheral conversion of other hormones in our body fat. Progesterone actually comes from cholesterol, and so it's a complicated process, but we're not making progesterone anymore from our ovaries. We'll get these teeny tiny little amounts, but that's essentially 0. Now, when we were releasing eggs, remember we produce progesterone after we release an egg to support the pregnancy if we were pregnant. We'd see numbers like 10 or 20 or even higher. So 0.1, That's 0. So not unexpected because this patient has not released an egg for some time. Now, the next set of labs is looking at kidney function and all the things that go through our kidneys, and it all looks perfect and wonderful. The little letters at the bottom that start with A, those are liver functions. Now, the AST and ALT, those are the primary liver enzymes that we look at. We really want those to be in the 20s or lower, not 30s. Even if AST, ALT are in the 30s, that can indicate that the liver is struggling for some reason, and one of the most common would be that we might be developing fatty liver, which is one of the things that happens with insulin resistance, as you remember from previous videos about that. Now, there's usually something curious on a lab that doesn't make sense. This patient's fasting glucose was 107. Now that is curious. So why is it 107? That's a lot higher than I would expect, given that she's got low insulin. She's not diabetic. We'll look at that later on. So I asked her lots of questions. Did you have anything to eat or drink? Anything at all? And she remembered, well, I put a teeny bit of coffee creamer in my coffee. And I said, that's what it is. So fasting means fasting. When we did it again, her fasting sugar actually was 85. And that makes much more sense. So we need to look at labs critically and ask a lot of questions, because a fasting sugar of 107 is in the straight up pre-diabetic arena. And so that was not correct. And I wanted to tell you that because it's important to see that sometimes labs don't make sense, and we've got to ask ourselves, well, why is that? How could that be? It's not adequate just to scan through these in 5 minutes, and that's why these visits take 60 to 90 minutes. But we did do it again, and it was 85, and so problem solved. Okay, on the next page. Jumping down to estradiol, remember that's the estrogen that we make from our ovaries. It was 0, less than 5 picograms per milliliter, means the lab couldn't find any. So now we have no estrogen and no progesterone. Not unexpected, but I think of that like trying to drive a Ferrari without any oil in it. Not gonna go really zipping around the track. We don't have the hormones that we need to feel good. So not unexpectedly, this lady's having hot flashes, night sweats, vaginal dryness, mood changes, sleep disruption. Makes a lot of sense. Now, going down a little bit, ferritin is our iron storage. It's a protein that stores iron. When we eat, we take most of the iron from our food or supplements and we make it into red blood cells, and that's great. And then what we have left over, we store in this protein called ferritin. So we want to have a lot of iron in the tank, because then when we are making more red blood cells, or if we lose blood for some reason, we've got something left over. So we really want iron for women to be at least 50 ferritin. 50 to 150, that's good. Now, if it was below 50, we'd really want to look at adding some in our diet or with a supplement, or making sure we're not losing blood from somewhere. So we can lose blood, obviously, when we're having periods, but a very common way to lose blood without noticing it is having colon cancer. So if somebody has low iron or ferritin and they're like not bleeding, I ask them about nutrition. Maybe they don't eat anything with iron in it, like red meat, dark green leafy vegetables. And then I make sure they've had a colonoscopy, because little bits of bleeding, we don't see it coming out because it's not red. So bleeding internally, sometimes it's invisible. So if your ferritin's really low and you're not having periods, rule out colon cancer. But this one's perfect. Okay, now interesting, we look at thyroid in a great detail. Now, many doctors just check this thing called TSH, thyroid stimulating hormone, and it's normal for sure. I was taught to just check that and then move on. But we can often miss subtle thyroid abnormalities when we do that, because it's not true that TSH is always abnormal when thyroid function is changing. In this case, her thyroid's pretty good. So if we look at it, free T3 and free T4, here they are. We do not want to be at the very bottom end of that range. Again, these are not optimal ranges, they're reference ranges. This patient's T3 is a little below average. Average T3 is around 3 to 3.2. Average T4 is right about there, around 1.2. So why is that? Why would someone have normal T4 and a little bit low T3? we've talked about this before, but T4 is the storage form of thyroid. The 4 applies to how much iodine is around the thyroid protein. So it's got 4 iodines around it. And it's in storage to be activated by one of those iodines being taken off, turns it into T3, and then we can use it. So sometimes the enzyme that does that conversion stops working properly. And that could be something as simple as having low selenium, zinc, iron. In this patient's case, she doesn't have low iron. If a patient's not symptomatic, sometimes I just tell them to take some selenium and zinc and make sure their iron's okay, and then check it again and see where we are. Iodine is also really important for the thyroid, so eating foods that contain iodine, like seaweed, or you can take a little iodine and supplement. A lot of controversy about how much. I've made a video about that before, but if you take something that's called thyroid support or anything of that nature, chances are it's got iodine, selenium, and zinc in it. So that would be a good idea because that enzyme that does the conversion from T4 to T3 needs those things to work. So the first thing we do is fix that and then check it again. And then some patients do need to take thyroid medication, but typically when the T4 is good, as in this case, and the T3 is a little low, it's because that enzyme needs a little TLC. Make sense? Okay, so we checked this thing called thyroid peroxidase antibody, and this patient's is 0, which is great. TPO, which is the short version of what that thing is an antibody that we produce in our own body that attacks this enzyme called thyroid peroxidase, and that is called Hashimoto's thyroiditis. She does not have it, but traditionally we diagnose it when the level of that antibody is greater than 30. Well, that's a made-up number. Basically, you don't want to have it at all. I mean, if you've got a level of 10 or 20, you got some version of autoimmune thyroiditis. It just happens to get the name Hashimoto's when it crosses that line, but as you can see, it's not you don't suddenly get sick when it becomes 30. We check everybody because some people think, and we found that maybe 25 or more % of women develop this antibody. It lowers thyroid function, and possibly more important, it's a sign that something's wonky with our gut. It's a sign of inflammation because, very long story, very short, we develop autoantibodies because of gut inflammation. So it can be a signal that something else is going on. That's why we check it. Not only because it can drop your thyroid, but it also generally means that your gut bacteria are not healthy. So she passed that one as well. Well, look, her testosterone is 2.5. That might as well be 0. We've talked about testosterone levels a lot. Now, we don't want to have male testosterone levels, like a young man would have a testosterone of 1,000. My experience in my own body and with our patients is we feel best when our testosterone is somewhere 50 to 100, maybe 60 to 120, something in that ballpark. And remember, testosterone, as you can see here, is measured in a different unit, nanograms per deciliter, than estradiol. And all that means is that you can't compare apples to apples. Actually, to make them apples to apples, you'd have to multiply the testosterone by 10. And that's only important when we're looking at numbers of estrogen and testosterone, just to say we have more testosterone, as you know now, in our bodies as women than estrogen. So testosterone 2.5, yeah, that's almost 0. And so what does that cause? Well, low sex drive in particular, difficulty holding on to muscle mass, lack of energy, all those things. So the main thing that testosterone has been studied for, and it has been studied in multiple very good randomized controlled trials, is to help with sex drive. And it absolutely helps with sex drive better than the placebo arm. Does that mean it helps everybody? No. But this patient, as she did, came saying she had no sex drive, along with vaginal dryness because of the low estrogen, pain with intercourse because of the low estrogen. Testosterone could be a really helpful thing for her to try, so long as we get those levels right. We do not really want them over 100, just as they were when we were young, healthy women, right? We don't want crazy high levels. We just are trying to replace what was there before. So this patient could really benefit from that. Now, there's a lot of vitamins you can check, and actually doing micronutrient testing is not a bad idea. There's a company called SpectraCell that we use that we can do that as an additional testing if one wants to. But two of the most common vitamins that are low in almost everybody are vitamin B12 and vitamin D. And as you can see here, both of these are quite low. So B12 of 420, well, that's not critically low. Optimal in this case is at the higher end of that range, so 800 to 1200. So I did recommend a B complex supplement for this patient. So B complex because we didn't check B2 and B6. So we can just give B12. I take all three together because all three, as you remember, as I was talking earlier about homocysteine, are really important in our metabolism, not just for methylation, but also for all the pathways that create energy. So B12, a little bit higher would be great. Now that vitamin D is just unarguably too low. 23 is a very low number. Ideally, we want to be 40 to 60. When we see numbers that are 20 and getting down less than 20, we see significant bone loss. It can contribute to osteoporosis. Vitamin D is involved in so many processes in our body. It's intimately involved in the way our muscles contract, so we can get tiredness, fatigue, cramps, lots of things. But primarily, we're talking here about protecting our bones. So a vitamin D supplement would be great. Now, we give vitamin D typically this is vitamin D3, with vitamin K2. The reason is they are synergistic. They help each other to absorb. So you might see products that have both of those together, or even vitamin A, D, and K together. So a typical amount that we would want daily to keep it stable would be about 2,000 international units a day of D3. For someone this low, I would recommend 5,000 international units a day for about 3 months. Check it again. And if it's in that target range, then we can drop down to, say, 2,000 a day. So the way I do that personally, I have the 5,000. Now that mine's back into a great range, I just take it 3 times a week. Monday, Wednesday, Friday. Obviously, that's 15,000 a week, which is more or less 2,000 a day. So the nice thing about vitamin D is you don't have to take it every single day because it is stored in our body fat. It lasts for a long time. So you can take it once a week. You can take it twice a week. The total amount you get during a week is what's important, and it doesn't have to be every single day. So once you get it up, so this patient, I'll give her 5,000 units of 80K product, and I'll tell her to take it every day for 2 months. And then if it's back to the 40 to 80 range, then I'll say, hey, back off and take it just 3 times a week. That makes sense? So basically every other day, plus or minus. Follicle stimulating hormones. So this is an interesting one. That's one of the hormones that comes from our brain, our pituitary gland, and it has one job in life, and that is to stimulate the ovaries to release eggs. Well, it never stops trying. This is a high number. Of course, it's not flagging as abnormal. If you look up, again, kind of comical that having an estrogen of 0 is also not flagging as abnormal. I mean, seriously, estrogen of 0 is just like in the normal column. I just think that's kind of funny in a sad way. It might be normal, but it sure isn't optimal. So if someone's just scanning down the labs with their eyes looking for stuff that's falling out into the normal or abnormal column, they're just going to say it looks fine. And this is where things get missed. So yeah, estrogen of 0 is normal because you're 56. I don't think that's probably what I would say. Anyway, FSH of 56 also not reading as abnormal, even though it's very high. So when we're young and fertile, let's just say we're 20, like my teenagers, their brain just has to produce the tiniest bit of FSH, like boop, and the ovaries are like, they don't need much stimulation. But as we get older and the ovaries are starting to slow down, we need more of that stimulating hormone. It's like, come on, ovaries, let's go. Let's produce an egg. Come on now, let's push you along. And so we see that FSH going up. When it gets over, say, 10 to 15, we typically say perimenopause, and that's a completely made up arbitrary line. It's just saying, hey, your ovaries are not responding like they used to. And then it keeps going up over time. And the poor little thing, it never figures out it's not going to work. So it keeps trying. So our pituitary gland, even if we're 90 years old, it's still pouring out masses of follicle stimulating hormone, trying so hard to get the ovaries to wake up. Kind of a sad story. So I think of these like little people. When we give this patient some estrogen, which we did today, when we measure her FSH next time, it's going to have dropped dramatically by at least 50%. And I think about the little pituitary gland just going, yay, we did it. Whew, we made some estrogen. We can relax and put our feet up. And we can say, no, you didn't, but you can take credit for it. Our brain is calming down. Think about it that way. In this state, our pituitary gland is on fire, like, something's wrong, send the firemen out, we've got to make some estrogen, panic. Calming down the pituitary just sounds like a good idea, doesn't it? And frankly, nobody's really studied what the effect of having really high FSH is for years, but it's got to be something. There's no way you can pour out masses of a hormone without it causing some downstream effects. 10 years from now, we'll know more about that, but long story short, we want it lower. And if it drops by 50% on estrogen, that's another way of us knowing that you're getting enough, because your brain is saying it's enough. So there's a lot of questions about how much estrogen is enough. One of the ways is, well, your symptoms get better. Another way is your brain is responding in a way that shows us that it's enough. So it's dropped by about 50%. So in a few weeks when we draw these labs again, we would see her FSH drops to, 25, something like that. And that will be great. Okay, so next page, hemoglobin A1C. Remember we talked a lot about that regarding diabetes, insulin resistance. So 5.4, is that good? Is that not good? Well, it depends, because we would need to look back and see what this patient's hemoglobin A1C was in the past. Because if it was 5.1, 5.2, 5.4, that means it's going up. And that's not a good trend, because this is indicating what our blood sugar has been for the past 3 months. So how does it do that from a single blood test? It's quite interesting. Our red blood cells live for around 3 months. And so there's a cool test that can be done to look at how much sugar is in the red blood cells. It's called glycosylation. And then this fancy calculation can guess what your average blood sugar has been over the past 3 months. So in this patient's case, estimated average glucose is 108. Well, that doesn't sound terrible, does it? But we really want it to be closer to 100. That might sound nitpicky, but if it used to be 90 and now it's 100 and now it's 108, and you can see where this is going, we want to intervene before it's actually in the diabetic range. Now I know, because this patient lost a lot of weight and she previously actually was diabetic, that this is a huge improvement for her. It used to be way over 6. So this is much better for her. So in her case, 5.4 is great. Now, different patient, it might be different, because what we really want to know is the direction that it's been going over time. Make sense? So 5.4 could be good or it could be not good, depending on what it was before. Make sense? So estimated glucose, we want to be closer to 100, but this patient's estimated glucose used to be 140. So hey, we'll take it. And then looking below, what we call a complete blood count. If you just look at the hemoglobin hematocrit, that so-called blood count, that tells if we're anemic. So iron deficiency anemia would usually show up as a low hemoglobin hematocrit. So this patient's hemoglobin is very good. We want it to be something greater than 12. All the rest of the aspects of her CBC look perfect. If any of those were abnormal, it could be something as simple as an allergy, a cold, a response to something, our blood cells doing what they're supposed to do to get rid of inflammation. But in this case, it all looks absolutely perfect. So this patient's labs are really pretty darn good, with the exception of hormone depletion. So everything looks perfect. Now, it did not look perfect before. It looks perfect because she lost weight. Lots of weight, and got rid of all of the lab abnormalities that she had before. But just picking up on some of the things to remember, estrogen was 0, progesterone was 0, testosterone was 2.5, which might as well be 0. low vitamin D, low vitamin B12, iron looks great. T3 is a little low, so we want to address that enzyme that converts T4 into T3. And then in her case, the hemoglobin A1C looks good, but I would definitely want to check that every year and follow it to make sure it continues to stay that way. And then just reminding you, if something looks a bit weird, like fasting glucose of 107, we need to dig and ask questions. Why is that? What could that be? In her case, it was a little coffee creamer, so we did it again and it was fine. So what did I recommend for this patient? Hormone replacement. All of her complaints, hot flashes, night sweats, insomnia, mood swings, vaginal dryness, pain with intercourse. Now, she didn't have the weight gain complaint because she's been on a massive weight loss journey, but that's a very common one. Each of those is related to hormone depletion. So we decided as a team to start her on a combination of estradiol and testosterone. We talked about all the different options for how you can get that in your system. As you recall, there's many options. The only ones we want to avoid are taking those by mouth because they're not good for the liver. So it could be a cream, a patch, drops under your tongue, something that dissolves in your mouth, even an injection. She opted for hormone pellets. So today she got a very low dose combination of estradiol and testosterone in pellet form, as well as progesterone, which is taken by mouth. Now remember, we take progesterone by mouth for a couple of reasons. One is it's safe for your liver. Two is it makes you sleepy, which is great if you have insomnia, right? So we take it at night, and it's designed to have a higher level during the sleeping hours and then to pretty much wear off in the morning, because if we have high progesterone in the morning, we wake up feeling groggy. So that is why we don't put progesterone in a pellet, because you'd be walking around sleepy all day. Now, she could have chosen progesterone cream, but I don't like it because the absorption's very unreliable. We don't know how much you're getting, and because progesterone prevents uterine cancer, and this patient has a uterus, we want to make sure she's getting plenty. And the absorption is much more reliable by mouth than through a cream. So from progesterone, she will get better sleep. It's good for hair, skin, nails, moods, uterine cancer prevention. The estrogen's going to get rid of those hot flashes, night sweats, vaginal dryness. It'll also protect her bones. Now she's going to get a bone density test because now that she's a very slim woman, she's at high risk of bone loss. We also ordered a mammogram because she hadn't had one in a year. And now regarding estrogen and breast cancer risk, I think we've talked to death that estrogen does not cause breast cancer. Being a woman causes breast cancer, so we all want to get a mammogram every year. Testosterone might reduce the risk of breast cancer. There's some really interesting studies that are suggesting that might be something we can say with certainty in the next 10 years. So as far as cancer in general, when we start patients on combined hormone replacement, estradiol, progesterone, testosterone, estradiol reduces the risk of colon cancer. That was proven in lots of studies, including the Women's Health Initiative. Progesterone reduces the risk of uterine cancer. That's cool. Testosterone has either no effect on cancer or it might reduce breast cancer risk. So we've got reduction of 3 different cancers, as well as reduction in osteoporosis, cognitive decline, including Alzheimer's, and cardiac disease. So that's awesome. So lots and lots of benefit and very negligible risk for a healthy patient like this. So in addition to the vitamin D and the vitamin B complex, I tell all patients omega-3. I asked her if she ate fish. She said she ate fish once a week. That's not enough. We need 1,000 milligrams of marine-based omega-3, that's DHA and EPA combined, every day. So if you ate salmon every day, that would be enough. But if you don't, then you want to check, and I've said this many times, check your omega index. I'll show again a picture of the omega quant test. You can order it online. Find out your omega index. If it's already over 8, great, you don't need anything. If it's below 8, eat more fish and or take a supplement. So much evidence showing that omega-3 is good for many things: cardiac disease, moods, brain health, reduction in dementia, lots of things. And then magnesium and calcium. Now this patient happens to eat dairy, so we looked at her nutrition. We talked about getting 1,000 milligrams of calcium a day. She's getting close to that. Not going to replace that in a supplement. Magnesium, really important. Pretty much everyone's deficient. Lots and lots of things magnesium's involved in, actually over 300 enzymatic processes in our body. You know, controversial whether it helps with sleep, but it might, so I take it at night. And then there's lots of types of magnesium. I'm going to do a separate talk just about magnesium because it's so complicated, but 400 milligrams a day of elemental magnesium. Take your pick: magnesium oxide, glycinate, threonate, citrate. Now, mag citrate might give you diarrhea, so many people are favoring magnesium glycinate these days. It's kind of the flavor of the week. Take a look at how much is in there. Now, we need 400 milligrams a day total, including from our food. Now, food sources are green stuff because magnesium's in the green chlorophyll that plants are made with. So if you eat lots of green plants, you're getting magnesium. So most supplements will have maybe half of that in the supplement. Maybe you're getting 150 to 200 milligrams in your supplement and the rest in your diet. So those are the supplements that I recommended for her. And then she's going to come back in 6 weeks, and we're going to check those things that were low again and make sure that they're optimal. So for her estradiol, we want it to be somewhere in the 40 to 80 range, plus or minus. Now, there's no perfect number, but a number that makes her symptoms go away and not high enough to give her opposite symptoms like breast tenderness, water retention, etc. And then testosterone, remember, we don't want it over 100. We want to make sure it's right in that normal healthy range for females. I don't actually check progesterone because if we draw it in the morning, it's going to look really low. If we came to your house at midnight and drew your blood, it would look high. So if you're taking 100 milligrams of progesterone, that's enough to prevent uterine cancer. We don't need to check it. Now, if you're really sleepy in the morning, I would check it because it may be that your progesterone isn't being metabolized as quickly as it should be, and then we would either take it earlier or drop the dose or something of that nature. But if you're feeling good, we don't usually check progesterone because it's going to look pretty low by the time you wake up in the morning. If you really have insomnia, we take 200 milligrams. That's what I take. So that is what I would ask for if I was going to have labs done. Some additional things that you could add are a C-reactive protein. That's a particular non-specific marker for inflammation. So if you've got symptoms of inflammation, joint pain, rashes, tummy upset, etc., CRP is really interesting. Other things we do in certain patients, depending on their particular symptoms, are doing a gut health panel. Thorne makes a really good one, checking for the health of the microbiome. Other things that you can do at home is a cortisol test. You're checking it 4 times a day to see what your cortisol curve is. That would be for someone who's maybe not sleeping, feeling really stressed. If they're wearing a glucose monitor, noticing that their sugar's doing lots of crazy highs and lows. So there's additional things that we would add depending on the patient because everybody's different. But what I showed you today is the basic panel that we would start with, create a plan for you, individualized for you, and then go from there. So that's an example of what you might expect if you come in for a new hormone visit, only it would take 60 to 90 minutes, so we shortened it a little bit. And I hope that was helpful. We'll put a list in the show notes of what all those labs are. And we can see you in Houston. We have 2 offices in Houston at Complete Midlife Wellness Center. We also see patients virtually. If you live in Texas, we can practice medicine since we're only licensed in Texas. If you live outside of Texas, we can still do coaching and education. Not officially practicing medicine, but if you happen to have some labs done, we could certainly discuss those with you because that's in the coaching and education bucket. So our virtual program has extended to anywhere in the world. And that's great because there are not enough doctors who are helping women in midlife, in my opinion. So we want to help as many of you as we can. So that's what I have to say about labs. I hope you learned something today. If you like this episode, don't forget to subscribe, share it with your friends, and I can't wait to see you next week.